unlike every other appointment they make in oncology, this one is not just about them. Once we find out something about you, we know things potentially about a lot of other family members. Big challenges with testing children and young adults is that emotional maturity. And if it's not going to change their care, we usually encourage them to wait because they'll be better equipped. They'll have more life experience to deal with it when they're a little bit more mature. The biggest misconception is that it's just like, ordering any other test and that the interpretation is black and white. As you can see that it's far from black and white. In fact, it's more gray than anything in a lot of cases.
You're listening to the Oncology Nursing Podcast, where ONS Voices Talk Cancer, a resource from the Oncology Nursing Society. Through conversations with subject matter experts, we examine the important issues in oncology nursing, from new treatments to patient-centered research to advancements in clinical practice. Join us as we hear from nurses in all facets of oncology care, from bench to bedside and everywhere in between. Welcome to the Oncology Nursing Podcast. Hello, and welcome to the Oncology Nursing Podcast. I'm your host, Stephanie Jardine, Oncology Clinical Specialist at ONS, and today we are joined by ONS member Suzanne Mahan, professor at St. Louis University in Missouri, and member of the St. Louis ONS chapter, to discuss ethical dilemmas and implications nurses and patients may face in germline testing, including informed consent, privacy concerns, and more. AstraZeneca sponsored this podcast episode, which is brought to you by ONS. Thank you for joining us today, Suzanne.
Thank you for letting me talk about something near and dear to my heart.
Well, I'm excited for us to get started. So to start us off, we're going to talk about some ethical principles that are involved in germline testing. So there's 4 of them, and I'm going to ask you if you could explain them to us. The first one would be autonomy.
Right. Autonomy means that the patient has the right and the ability to make the choice of whether or not they want a treatment or a test. And autonomy comes up actually fairly often in my practice, and there are multiple ways it happens. One that often happens is a parent tests positive for a pathogenic variant, and they want their 8-year-old daughter tested for it. Now, it's something that we're not going to do any kind of screening or anything different till, the child is 25 or 30 years old. And the parents say, well, we just want to know. And we will talk about this prior to testing, that most of these are adult susceptibility cancers, and we are not going to test children. But then when it happens, they want to do it. And in most cases, we will not test minors because it's not going to change their care. And the principle behind that is that the individual should get to choose whether or not they have that test. Now, if it's something that's associated with childhood susceptibility, then that's a whole nother story. And then we will test the minor with the parent and the child to the extent they are possible consenting. But if we test an 8-year-old for something, then, and then they turn 30 years old and they're like, well, I didn't want to know that, we've robbed them of their autonomy. On the other end of the spectrum, we see it a lot of times as well. Sometimes a parent is the best person to test because they have the diagnosis of cancer. But the parent says, I don't care. I've lived a good life. I don't want to know this. But the child's like, well, if we tested you, then we'd have a better idea of what we're going on, what we need to be worried about. And the parent is the best person to test, but the parent doesn't want to test. And so once again, the parent isn't making the decision about whether the test, their child is making the decision. And that's not respecting autonomy either.
The next one is beneficence.
Beneficence is doing everything we can to maximize benefit and well-being. And this happens a lot too. We want to do what's best for our patient. I think a place where we often fail to act with beneficence is in terms of cascade testing. So cascade testing means we've identified something in the family, and then the next we test siblings and other family members, and then the next generation as appropriate. So if you order testing and you're only taking care of your patient, who's going to take care of the rest of the family? And if we don't take care of the rest of the family, we have not maximized. In fact, we've lost one of the biggest benefits of genetic testing. So, in order to maximize, you have to have someone that's going to coordinate care for the entire family. Another example would be doing exome testing, where we're looking at an entire genomic makeup. And, you might be doing it to understand a specific problem. But as you do go through all that, you can find other things. You might find they're at risk for a disease, a neurologic disease for which there's no treatment. So before you embark on that, you have to talk to the family. Like, if we find out these other unexpected findings, are you going to want us to share those with you? Because what's going to be better for you? Do you want to know everything, or do you not want to know everything? So it's trying to balance what that individual wants.
Great. The next one is non-maleficence.
So this is, our duty to avoid causing harm or doing everything we can to minimize harm. And this is one that I think is critical to, oncology care. And this is why it is so important in germline testing that the person ordering that testing can really be able to order the correct test. They have the capability and the knowledge base to do enough assessment to order the best test and the correct test. Because if you don't order the best test, you can potentially, harm that patient and family. Another example would be interpreting it. When those tests, you shouldn't be ordering something that you don't know how to interpret the test. And, it's that competence and the ability to do that. So if you can't do that, you cause harm. Another kind of quiet place that it happens, and it happens more than potential, it's a potential problem that can happen. I have a family member, come and they'll say, my paternal aunt has this mutation or this pathogenic variant, which is really the more correct term, in the CHEK2 gene. And my dad says he doesn't want to test, but I need to know because I want to make decisions about breast care and colonoscopy and whatnot. So we know that the family carries it. Now, if the patient tests positive for that pathogenic variant, we know that the father carries it. So the father just kind of found out through the back door that he carries it. So it's not only autonomy, but that could be harmful to him because he didn't want to know that information. So, we always have to kind of think with this, it's not just the person that's sitting in front of us right now. And I always tell families when we're on calls with them, and we prefer that we have multiple family members in the visit or on call, because unlike every other appointment they make in oncology, this one is not just about them. Once we find out something about you, we know things potentially about a lot of other family members. And I think we call that, realizing that someone's an obligate carrier, when just because we know where they sit on the tree that they have to carry it. And that can be a very devastating information for a family member.
And lastly, justice.
So justice is probably one that's kind of the easiest of these to kind of think about. And that's that we are treating everybody fair and equitably. And I think we've made progress in germline testing with justice, but there are still a lot of challenges. So insurance coverage is better for genetic germline testing than it used to be. It used to be that if you just didn't have good insurance, you couldn't get it, and it was cost prohibitive. So there were whole groups in the population who could never afford genetic testing, even if they would benefit from it. But there's also this whole thing of, do we offer it to everybody? Are there some groups of people that they should be offered, but we don't because they might be slower to understand it, or they haven't been real good about keeping other appointments. If a patient's appropriate for testing, they should all be offered the option for counseling, not just, because we've kind of made a decision that it may be easier, or, there could be financial barriers. Now, for me, I've had, 20 plus years in this position, and I've always had funding. So if someone needs genetic testing and they're just uninsured, or there's extenuating circumstances, we have been able to underwrite the cost of that testing. And patients are like, oh, great, now I can get the testing. But you have to also say, okay, but if you get this testing and you test positive and you're uninsured or whatever situation caused you to need financial assistance with the testing, you're going to have that complication again with the follow-up. And so, just trying to make those services, available across the board is harder than it looks. The other place that we've had, although way better since the pandemic, is that the accessibility and ability for someone to actually access a genetics professional. So in the past, I take in patients from, probably the eastern half of Missouri and the southern half of Illinois. Those are all patients that might come see me. And so, in the past, they would have to drive to my office, which might be a 3 or 4 hour trip. They'd have to take a day off work. They'd have the fuel costs to come. They'd take another family member, take the day off work. So it wasn't real accessible. And that became kind of a barrier, making it really not just across all people to be able to access that service. With telehealth, now that we can call people and they may only have to free up 90 minutes for that visit, it's a much more accessible, but you have to kind of think about how do we connect patients with those, genetics professionals who provide the service.
Thank you. I'm sure we've all thought about all 4 of those principles and used them in different ways, but it's great to hear those examples that you had specifically for germline testing. Are there any other ethical principles that nurses should consider in germline testing?
I think informed consent it kind of traverses through all of those principles, but I always say the pre-test counseling may be more important than the post-test counseling. So we schedule patients for a 90-minute appointment when we, on average, are probably on the phone with them about 75 minutes or so. But we never want a patient to be rushed. But when, to actually inform a patient, we have to do enough assessment of the personal history, the family history. We have to review previous testing. So there's an assessment component to that appointment. But then there's the whole consent thing. They need to understand why we might be recommending a particular panel of genes. Who is the best person to test? They need to be able to articulate why we're recommending this person be tested over maybe the person that initiated it. Then we have to talk to them about the potential benefits of testing, understanding risk better. We have to talk about the limitations of testing. It's not perfect. There could be things we don't have the ability to test for. You can get a variant of unknown significance. We have to talk about the meaning of various variants that are negative or that are benign that don't mean anything. We have to talk to them about how they would be informing other family members if we found something and the implications for other family members as we move through it. We have to talk to them about potential discrimination. And although their health insurance and employability are largely protected through the Genetic Information Non-Discrimination Act, there is not protection for life, disability, or long-term care insurance. Those are all things people should understand prior to testing. And that's a mouthful of lots of things to talk to families about. We are way beyond, hey, this is a quick blood test we can, tack onto the CBC as they walk out the door.
So with that, what would you, when you're doing this pre-test counseling that you do to give the patient all of that information, like you've just discussed, how do you know, or what do you look for that tells you that a patient fully understands and they truly have informed consent to go forward with the testing?
I think we've gotten a lot more savvy with this, with the telehealth. And honestly, a lot of mine is done by phone because I have a lot of patients that don't even have the capability for video. So if they're in the office or with video, sometimes you can just tell from the look in their face and their eyes that maybe they didn't understand it. But, because we're doing so much of this remotely by phone, I typically look at those sections and I'll say to them, so can you tell me in your own words why we're recommending this test? And then can you tell me in your own words what you might benefit from? What might be the good things that could come from this? Can you tell me what the risks are? And if they can't really name just in general And sometimes they'll say, I don't think I understand it. Then I have the option to jump back in and kind of correct it or, go over it again. And so that is largely how I approach it now. And that's partially why it's so time consuming, but it's so important for people to understand it before they test, because then when we give results or we start making recommendations, they kind of knew that was coming.
That's a good way to make sure that they do understand, asking them to repeat that back to you so that you can decide if you need to go in a little bit more depth of what it is, or they really, really just don't have any idea of what is going on.
I would say in most cases, there's at least one or 2 points we have to kind of, I don't know, reiterate or review, or, maybe I need to try to kind of find a different way to say it or a different example to help them understand it.
I'm sure using examples are a very, very large part of what you do with just the explanation process and the whole, even once you get those results back, explaining how, what those results are.
Absolutely.
So, how can healthcare professionals uphold their Hippocratic oath in terms of germline testing?
So, the Hippocratic Oath is basically saying, you're going to be a good and ethical and moral person. And I think one of the most, and I will say it over and over again, is that if you don't really understand the in-depth intricacies of ordering genetic testing or interpreting it, that you have a responsibility, and really the prudent and the kindest and the best thing you can do for your patient is to refer them to a genetics professional. It really helps us to meet with that patient at the front end rather than the back end. I would say every week I have 5 or 6 consults from providers who ordered testing and then they didn't know what to do with it. And those are always complicated for me because, I'll look at it and I'll be like, well, I would have done this differently, or the assessment was not adequate. And now we need to order more things, and that might come at a cost for the patient, or the patient had no idea that this was a possibility. So to understand what your competence is, anybody can probably order testing if it's within the scope of practice of a physician or an advanced practice nurse to order testing, but is it within the scope of your competence to order it and manage the whole family? And I think that the Hippocratic Oath tells us we need to not only be able to have it as scope of practice, but it has to be within our scope of competence.
So you've mentioned families a lot and how having genetic testing done is not just about that person who you're testing, but how it can affect an entire family tree. So once a patient gets their testing back, how can a nurse demonstrate the importance of sharing those results with family members to those patients?
So the family is my unit of service. In fact, our charts are kind of kept by family as opposed to individual. And I have charts where we have 45, 50 family members that we've tested or, interacted with at some point over many years. So the family is the unit of service. When we do pre-test counseling, we're going to talk to a family member and say, if we find something in this genetic testing that other family members should be offered testing for, we explain to them that it's their responsibility because the HIPAA constraints, and privacy constraints, I can't call up all their relatives and say, guess what we found here? So that's their responsibility. And sometimes I'll have a patient on the call who's, fairly ill with treatment and their siblings on the call. And I'll say, if we find something, maybe your sibling can help reach out to all these other family members. So we want them to, first of all, know that they have to reach out to other family members. I think for nurses in any place in practice, if a patient shows up with a genetic test result and they say, hey, look what, it's germline and they found something, I think one of the questions those nurses absolutely need to be saying is, have you shared this with other family members, or do you know which family members to share it with, or did the genetics professional help guide you with that process? And, over the years, I've learned that now I'm going to date myself, that there are no leave it to beaver families. There are no perfect families out there. And so a lot of times families will say, I don't talk to my brother, or I don't talk to that side of the family. And we always talk to them in the pre-test counseling phase that if we find something that, we find a pathogenic, harmful variant in you, that could have implications for your brother. And I'm not saying you should go have dinner with your brother, but it would be important for you to, at least share that information with him. And we will help family members do that. We'll write letters that they can mail. We'll do all sorts of things to kind of help facilitate that. And I always say, and it's kind of all part of the ethical piece of it, I'll say, if your brother found something, he carried something, wouldn't you want to have the chance to get, if we flip the table, wouldn't you want to have that opportunity? And so those are very challenging parts of working with families. Some families, they share and everybody knows about it. And there are others where it's much more complicated.
Families are complicated, aren't they? So can you discuss the complications of coercion of a patient's family members while undergoing germline testing?
It's something that most genetic professionals, we think about this a lot. And as I said, our unit of service is the family. It's not really, we're taking care of individuals within the family, but my service unit is the family. So a lot of times I kind of open it up. We hope that they get this message when they make the appointment, that they're not making an appointment to do genetic testing. They're making an appointment to learn about potential genetic risk. So getting on the phone with me or having a visit in my office doesn't mean, you're going to roll up your sleeve and donate blood and get genetic testing. What it means is that you're going to learn about it. And a lot of times it's because of misconceptions that coercion can happen. So a lot of times when those kinds of things, when someone says, well, I want my mom tested, she doesn't want to know, but I want to know. So we would bring both of them in, and ideally on the same call, same time. And we'd say, well, these are the potential benefits, if we test your mom, and these are the potential risks. And sometimes people are like, oh, I didn't know it could do all that. Yes, I would like to test. And sometimes after they, I kind of explain all that to them, they're like, no, now I'm sure I don't want to test. So if mom says, even though she's got breast cancer 3 times and she's the best person to test, if she says, I don't want to test, I have to respect that. Okay. Then I have to work with her daughter and say, okay, we can test you. And here's the limitations of testing you. But I also want mom to hear, and if we test your daughter and she finds out she carries something, we may then indirectly know you carry it. So I think people need to be very purposeful about, understanding it, and that everybody needs to see it from their point of view, but also the point of view of the other person. And a lot of times after we provide that much education, the family kind of comes together like, oh gosh, I want to do that, or that is really in my family's best interest. Then we can move forward. But just testing someone without them really understanding how it affects them and their, the loved ones around them is not appropriate. Everybody needs to understand how it affects each. It's easy to see how it affects you. It's harder to walk in somebody else's shoes, but they need to be aware that it has implications for everybody.
So you've kind of given us or alluded to a positive or a good situation where once you have given the education to that family of what this information will mean, and they agree that it's definitely beneficial to the family to know this and to have, get the testing done. Let's talk about a complicated family dynamic that leads to an ethical dilemma. How do nurses help patients in those situations?
As nurses prepare patients for genetic counseling appointments, it's important that they understand and kind of communicate that this is a family affair. This is not just you. And a lot of times, we can, as I said, we can kind of correct it with discussion, but there are absolutely families, I spoke with someone yesterday And her father is hands down the best person to test first in this family. And he said, I am not doing it. We have spoken to him in we have spoken to them as a unit. And he's just says, I don't want to know that. And he said, I don't want to know my daughter's test results if she were to test positive. So, he has made it clear. He said he doesn't want to know. And we just have to respect that. I can't always wave the magic wand and get the best person to test. So then I'm going to test the daughter in this case. I'm going to tell her that I could have a lot of trouble interpreting it. I'm going to tell her if she tests positive for something high risk and opts for a risk reducing hysterectomy or something, her father's probably going to figure it out. And he may, learn through the back door. And is she prepared to accept that consequence? Sometimes there's just no best person or best way out of it. You do the best you can, but you never want to do it without trying to kind of look at all the angles and see who's the best person to start that testing with.
So, healthcare providers can't share patients' information with family members, part of HIPAA. And that would be the same with germline testing without having the patient's permission. But are there any situations where a healthcare provider is ethically obligated to share information, even if the patient hasn't given them permission?
We have to be really careful. So if your father or uncle tests positive for something and I want to test you for that specific thing, I need to see that test result. So I order the correct thing. And, that to make sure it all makes sense and that we're ordering adequately and whatnot. So there's the whole issue of what do we do with those test results when I have them? Because the patient gave it to me. Now he assumes that I'm only using it to take care of the family, but we can't put it in my patient's electronic medical record because you can't have someone else's results in there. So there's the whole thing of how do we handle those results? And most of us have some kind of alternate, secure system for keeping track of them because we have to prove that we ordered the right thing. So there's the privacy that way. But there's also the privacy you're saying, I know something about a family member and they have specifically instructed me not to tell other family members about it. If they've told me I can't tell them, I can't tell them. I had a case years ago where a father had tested positive for something and his daughter was potentially at risk for, it was a BRCA gene and she was potentially at risk. And all of a sudden when they were in the office, I realized that they were related. It hadn't come up, but her father had kind of an unusual name. And then, when she said his first name, I thought, oh my goodness. And, I looked at the diagnosis and I knew that was the parent and he had died. And I couldn't say to her, we know what your father carried. All I could say was, based on your family history, we're going to offer you testing and that we will manage you based off those results. But I couldn't say that I knew that. Now, it turned out she tested positive for, I offered her testing based on the family history and she tested positive, but I could never say to her, oh, I knew your dad carried it too. So you can't, even if you know it, you can't, you can offer them testing, in the hopes, if they show up that you covered the right thing, but you can't share someone else's results if they have specifically instructed you not to do so.
So let's talk a little bit about some of those younger patients. What would some ethical considerations of germline testing be if the parent has tested positive for a pathogenic variant? You've kind of alluded to some of that, but what if the children are very young?
So most of the things that we test for in oncology associated with germline risk, in most cases, we are not going to change screening till they're probably 20 or 25 years old, in which case they can consent and make the decision for themselves. If someone has familial adenosis polyposis, some of the SDH changes associated with paraganglioma and pheochromocytoma, medullary thyroid, there are syndromes, MEN, where we are going to want to test children, as young as 3 or 4 years of age. In that case, because we're going to start doing something 3, 4, 10 years of age. Depending on the child, we can say, this is, we're doing this because, and we'll kind of give them simple explanations. But if they're really young, the parent has to make that decision. The ones that I find incredibly challenging, and I've had just quite a few of these in the last year or two. 23andMe offers BRCA testing for the 3 founder mutations, pathogenic variants that are common in the Ashkenazi Jewish population. So they don't get full BRCA testing by any means, but they find these 3. And I can think of 3 patients in the last 6 months who, their parents bought them, 23andMe. It was like supposed to be this fun birthday present. And then a 16-year-old shows up with a positive BRCA, and they weren't ready to deal with that, because they just don't have the emotional capability. And it's very sad because we're not really going to probably change their screening till they're 25 years old or so, but then they kind of walk around with this. Parents, out of a lot of guilt, sometimes they test positive and they'll say, I just want to know that my child's okay. I want my child to have testing. And what they're trading on is, well, there's a 50-50 chance my child won't have that pathogenic variant. And if we know that now, there's going to be a lot of relief for us. But if the child tests positive, then we know this thing that's just kind of like the elephant in the room. There's not much we can do about it. And it causes, I think a lot of worry and anxiety. So those are things that, that we really think about. Even 18-year-olds can consent for testing. They can sign on the dotted line, they're an adult, but do they really have the emotional maturity to deal with that? And sometimes, during counseling, we want to know how they've managed bad news in the past, because, if I tell them they're positive for a pathogenic variant, well, that's going to be bad news. And if, they had a major depressive incident over something other bad news, I need to know that and say, is this in your best interest to learn this? So children who are 18, 19 years old really have never had bad news. Even 25-year-olds, a lot of them have never really had bad news. So it's hard for them to kind of walk in that situation and see how they're going to manage that information. And the other thing is, it's just developmental. If you're 25 years old and you're positive for something with a pathogenic variant, and we're talking to you about breast MRI or yearly colonoscopy, you don't have any peers that understand that. So, those are big challenges with testing children and young adults, is that emotional maturity. And if it's not going to change their care, we usually encourage them to wait, because they'll be better equipped. They'll have more life experience to deal with it when they're a little bit more mature.
Thank you for that. What a great example of kind of across the age range there, and how you guys, the genetic counselors, look at that and kind of help guide families when there are children involved. And so I appreciate that explanation. So you mentioned, if one person had testing done and they had a family member who might be in the hospital, that definitely the testing would show that there was a family history there, but that testing could not be in both charts, let's say. How does germline testing, or how do you store that to protect patients' privacy?
So in most cases, it's stored in a secure area as a family, because I can't put their information in their record. I might note that their paternal grandmother has checked to, and then I'll put the specific variant details in there. So we know that, we've seen it, and I'll usually write something like, have reviewed the actual test results. So they know it's not just the patient saying they had checked to, but it's like, I've looked at it and like it's real, and I have all the data about that. But I can't put the person's, it's not Uncle Tommy's stuff, or, we can't put any of that. We can't do any of that information. The same is true of pedigrees. The software enables us to put names on there, and that's incredibly helpful. We share those pedigrees with with family members and whatnot. But if I'm going to put that information in the chart, I have to de-identify it. Or if I'm going to, if I tell the family, if you're going to share this with your brother who's going to see a counselor in Texas, then I send them a de-identified one so that the counselor can see the family history, but they can't see the specific names. We do everything we can to protect that privacy.
Well, that's good to know. Thank you for that explanation as well. So we've talked a lot about, or all about, germline testing. But when a patient has that done, and let's say that they do get some positive results back, how can that help patients take preventative steps to lower their risk for certain cancers and diseases?
So one of the things I talk to families about, first of all, I always say that the testing is a measure of risk. Having an altered pathogenic variant does not mean you're going to get the cancer. It's not going to tell us if you have the cancer. It's an estimate of risk. And when we give recommendations for care, we look at the specific data about that particular gene. And for some genes now, we have more information that this particular variant is associated with higher risk. And in some cases, this particular variant is associated with not as high of risk. And the term for that is penetrance. So you might see on a report lower penetrance or moderate penetrance. So we look at that kind of information. And all of these are ordered, and the recommendations for care are based on the test results, the patient's history, and the family history. So if you have an altered CHEK2, and I have 3 other families that week with an altered CHEK2, they may have similar recommendations for care, but they're not all going to have identical recommendations for care. These are always things we look at that are actionable. So actionable means that if we find an altered gene, a pathogenic variant, there's something we can do about it. We can do more screening. We really don't offer testing if it's not going to change management. So the management can range from increased screening at a younger age, chemoprevention with something like tamoxifen, maybe for breast cancer, or some of the agents we're now looking at for colon cancer, or it can be all the way to risk reducing surgery, removing a thyroid, doing bilateral risk reducing mastectomies, doing a risk reducing colectomy. So it comes with a wide range. And when we work with families, especially if we know what the variant is that the family carries, we can give those families in their pre-test counseling pretty good idea of what a positive test result might mean, so they know what they're getting into.
Are there any ethical dilemmas that nurses might encounter around these decisions?
I think the whole thing of justice, can they actually get the screening that we recommend? One of the ones I think is challenging right now is pancreatic screening. Pancreatic screening with, an endoscopic ultrasound is probably the best way to screen. It's not readily available. It's expensive. A lot of times it's not like there's not a huge guideline, but sometimes I'll look at a family and I'll be like, boy, they have an ATM pathogenic variant and there's 2 relatives with pancreatic cancer. I think that they should have pancreatic screening. And so if I make a recommendation and then we're going to have a whole lot of trouble getting that recommendation actually into play, I think that is a potential ethical dilemma. And you kind of have to tell patients up front that, we're certainly going to work with you. We're going to do everything we can. And in most cases, eventually we figure it out. But it's not just like, oh, you can go get that mammogram. It's not that easy.
Well, Suzanne, I really appreciate all of your expertise in this area. It's definitely evident your passion in the area and the importance of this for families and patients who experience a cancer diagnosis. So we're coming to the end of our podcast now, and I have a few questions that I like to end every session with, and I just wanted to kind of do a rapid fire at you with these questions. And the first one is, what are common misconceptions about the ethical dilemmas surrounding germline testing?
I think the biggest misconception is that it's just like, ordering any other test and that the interpretation is black and white. As you can see, that it's far from black and white. In fact, it's more gray than anything in a lot of cases, So I think that if you're going to be involved in managing families and ordering, genetic testing, that you need to really be competent to do so you can be aware of all these things. And I think that the other big issue is that the unit of service is the family. If you find something in your patient and you fail to get the rest of the family tested for that, you've done a bigger disservice than service to that family. And it's just so important. We lose the biggest benefit of germline testing if we don't take care of the entire unit.
Next, what are some ethical dilemmas in germline testing that are not often discussed, but you wish people knew more about?
I cannot say enough that if you're not comfortable interpreting it, and if you think it's just like looking at that report and saying, well, this is what you do, you run the risk of actually harming that patient. The biggest thing you can do that helps your patient is to refer them to a genetics professional, because they manage it. And you should think of those people as part of the team. One of the breast surgeons says, well, I always send you to Suzanne because, this is all she does all day. I don't dabble in it. This is what I do all day. And she said, and Suzanne can't do your breast surgery, which is absolutely true. I have no business even walking by an OR. So, to really realize your limitations, and that to really embrace and use the genetics professionals. We want to be a part of the team. We want to be, helping families to get the best possible service.
Okay. And what additional training or education do oncology nurses need to have shared decision-making conversations with patients and families about germline testing and results?
All nurses should be able to kind of identify those red flags of who should potentially be referred for genetic counseling. So people with rare tumors, early onset tumors, when we see things on the tumor testing like microsatellite instability, triple negative breast cancers, and have ability to do enough family history to realize, boy, that's more cancer than we would expect by chance. So all oncology nurses, no matter what practice setting they're in, need to be able to identify those patients and refer them, and to really help the patient to say, we're sending you to this person because we're concerned, or you've raised the question of concern, and we want to try to get the most comprehensive evaluation possible. And then on the back end, after we see a patient, we're going to send a letter, or we're going to put something in the chart and say, this patient needs this, 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 and this. And it's usually a bullet list of, 10 or 12 recommendations for some of these that say, these are things we need to do. We need the nurses to help us make sure that actually gets delivered and carried out. So helping families to understand that we are a big part of the team and that they have to check back with us regularly is so important.
And finally, what are some additional resources for patients and providers who want to learn more?
Hands down, the Oncology Nursing Society has a genomics advisory board, and there are a number of us that have been working very, very hard to put together all sorts of resources. And if you have not gone to the Precision Medicine Learning Library, and it'll be linked with the podcast, and it changes all the time. In there, we have the proper taxonomy. We have case studies that you can review. There's continuing education information. There's a whole series of videos and articles that are, 5-10 minute videos and short papers, so you can kind of learn a concept. You could spend days and weeks in that learning library learning more. And every time you take that, that step to learn a little bit more about it, you will better understand and better be able to help guide your patient.
Well, Suzanne, again, thank you so much for your expertise and for sharing with us today. Do you have any final comments before we go?
No, I just want to thank you for allowing us this opportunity to kind of get the word out about all those resources and to help nurses to really understand the complexities of this process.
Well, thank you again.
Thank you.
Thank you for listening to the Oncology Nursing Podcast. Tell us about your favorite part of this episode by leaving a review on iTunes or wherever you downloaded your podcast. For more resources and information about oncology nursing, visit us at ons.org or voice.ons.org. The ideas and opinions shared in this episode represent those of the guests and not necessarily ONS.